Hello, good afternoon, everyone.
Good afternoon, sir.
Please, can you see my screen?
Yes,
Yes,
sir.
sir.
Yes, sir.
Okay, thank you. So I think last week we got to this stage. Please mute. So when it comes to infection, there are four main stages, and each of these stages is classified as an infection. So long as the organism is multiplying and the organism has invaded the tissues or the organs. So once someone comes into contact with, you have initial multiplication of the organism, where the individual does not feel much of the symptoms. So the symptoms are non-specific. Then it progresses to the prodromal stage, where the symptoms become more evident and the number of microorganisms also increase. Then it gets to the height of the infection, where symptoms and the signs become more visible and the condition becomes severe if not treated or managed properly. And mostly diagnostics are done and is very accurate when the height of infection is achieved. It also depends on the diagnostic technique. So in some cases, at this stage, when the organism is incubating, you may not detect it until it gets to the height of infection. Example, for malaria, in the incubation stage, where the organism resides in the liver, until it comes into the bloodstream, symptoms are not seen by the individual. For some organisms, whilst they are incubating, they can be shared into the environment. Please mute. Through another portal of exit, then transmission can go on. For some of them, at the incubation stage, they cannot be transmitted. So it varies from one organism to the other. Then treatment begins and the patient responds to treatment. So the number of microorganisms also reduce until they are finally cleared. If treatment is initiated and the organisms are declining and the patient feels better and stops the treatment, they could also multiply again and then reach the height of infection. So we should always monitor treatment. Sometimes the symptoms may go down or will not be visible, but the organisms will be there. So if the treatment is not fully done, then the infection can recur. So when it comes to the establishment and spread of these infectious agents, they could be confined to a particular tissue, or organ. And this is termed as localized infection. Sometimes you can have the infection spreading to several sites, several tissues, several organs. And usually you find them in the bloodstream or the lymphatic system. So this is termed as systemic infection. So spreading from tissues to organs and then affecting the system. The system is made up of organs of different types that perform the same function. Then we can have a localized infection, which will then spread to other sites, but not several sites. So it can move from the intestinal tract into another site, or you can have respiratory infection, then develops into meningitis, affecting the brain. So if it does not spread to all sides, but from one side to the other, then it is focal. Assuming you have wound infection, and then it begins to spread to other sites. This is focal infection. So localized is when it's confined to one region or site within the host. Focal is when it spreads from one part to the other, and not all the sites or several sites. If it spreads to several sites, for example, in the bloodstream, where it is carried to all parts of the body, then it is systemic. So with the patterns of infection, we could have mixed infection. Mixed infection is when you have several or more than one organism growing at the same time at a particular site. So if you have 2 organisms or 3 organisms, Salmonella typhi, Staphylococcus aureus, and Klebsiella pneumonia, growing and multiplying at the same time in the blood, that's the same site. So this is mixed infection. But if you have 2 different pathogens in the host at different sites, so if one has gastrointestinal tract infection, and then the other organism is found probably in the mouth, because they are at different sites, it is not mixed infection. It could be in the same host, but at different sites, but it is not mixed infection. Mixed infection is when you have all the organisms, more than one or several of them, at the same site. It can be polymicrobia when there are many, so more than 3 polymicrobia. Sometimes you can have a mixed infection where one organism or one pathogen, please mute. So one pathogen sets in, invades the tissues, and then multiplies. Then care is not taken, another pathogen or other pathogens set in, and then they also invade and multiply. So the first infection is a primary infection. The subsequent infections are the secondary infections. So the secondary infections can result at the same site or at different sites, or at the same site and at a different site. But mostly you have the secondary infection occurring at the same site if care is not taken. And this happens mostly in people who are aged and have the immune system compromised, or those who don't practice hygiene. You can also have an acute infection or chronic infection. So acute is when sets in rapidly, but it does not stay longer. And mostly the symptoms are more severe and they require prompt management. For chronic, they can progress from the acute to the chronic stage and they persist for a long period. Sometimes they could be chronic and they recur. They are not showing at some point, you don't see the signs or the symptoms, then they recur. Meanwhile, the organisms are there. So some can be in the dormant stage where they keep recurring. And those who are having the chronic infections mostly spread it in the communities. So we could have these manifestations resulting from inflammation. Can have fever, pain, soreness, and swellings as a result of the infectious agent in the host. And as the immune system tries to fight back. So sometimes the organism produces toxins in response to the fight from the immune system. And there could be edema, which is an accumulation of fluids in the tissues, which results in swelling. This is in response to the fight from the immune system. There can also be granulomas in the case of the chronic infections, where these are solid collections of inflammatory cells. They could be white blood cells that have solidified at a particular site as a result of the immune response. There could also be abscesses, where you have, this time not the solid type, but the fluid collection of inflammatory cells in the case of the acute infections. Sometimes the lymphatic system becomes affected. So this affects how the extra fluids are filtered from the bloodstream. So you can have lymphadenitis, swollen lymph nodes as a result of these inflammations. Sometimes patients come and blood samples are taken and we could use the white blood cell or the other blood cell types to know the signs of an infection in the blood. Sometimes not only in the blood, you can also use the blood cells to know the conditions in other sites of the body. So if you have an increase in the white blood cells, that means the body is trying to fight an infection. So it gives a clue to some of these infectious diseases. So people who have decreased white blood cells, leukopenia, tend to be at risk of fighting the infections better because the white blood cells are needed to respond to the invading microorganisms. So we have septicemia, which is as a result of microorganisms multiplying in the blood. So they multiply and then achieve higher numbers. So the presence of microorganisms in the blood is termed as septicemia. If the microorganisms are bacteria, then it is bacteremia. If they are viruses, then it's viremia. So the presence of these microorganisms in the blood. But sepsis is different from septicemia. Sepsis is when you have the microorganisms infecting the host tissues or organs. And as it becomes more severe, the immune system also tries to fight back. So this extreme response can sometimes lead to organ failure or tissue damage, or sometimes death. This is what is referred to as sepsis. So septicemia is when you have the microorganisms in the blood, but sepsis has to do with organ or tissue damage as a result of the body's extreme response to an infection. So you could have an infection, microorganisms are multiplying, invading the tissues or the organs, but the host does not show symptoms. And such people do not go to the health facilities for treatment because they don't feel any need to go. So these are termed as asymptomatic or subclinical infections. Subclinical infections are different from submicroscopic infections. So subclinical is when the individual does not show symptoms. Submicroscopic, sometimes the individual will show symptoms, sometimes they will not. But the numbers of the microorganisms are too low to be detected by the microscope. So to know such individuals who have asymptomatic infections, screening is the best option. Once you screen the people in the community, then you can identify those who are having asymptomatic infections. That's why sometimes mass drug administration is given so that the control of the disease will be achieved, especially in asymptomatic cases. When the microorganisms are multiplying, there's also a portal of exit that they can use to infect other people or come out into the environment. So in the case of respiratory infections, someone coughs or produces sputum, the organisms could come out into the environment, and then the healthy susceptible host will be infected if they come into contact with such people. Sometimes runny nose could also be an exit point for these microorganisms. Saliva could also be an exit point. So if you share cups with such people who are infected, they could also have a way of getting into the other people. So if you are living with chronic carriers, these people can easily transmit to other people. So sometimes in the case of skin infections, you can have scales that are peeling off, and if the person shares clothing or towel with somebody, they can easily be a source of infection. Sometimes the organisms come out through feces and they can contaminate water bodies or food stuffs, and then they can be shared with other people. So if somebody uses a washroom and then does not clean well, they can also be contracted at the site, or the person comes out, touches objects, and then these are also touched by other people, and accidentally they put their hands in their mouth or they eat without washing their hands, they could also contract the infection. Sometimes oral exits, urogenital tracts could also be the portals of exit. Sometimes there can be removal of blood, and it depends on the condition. So in the case of Ebola, where blood comes from the mouth, the nose, and other openings. This could be a source of infection to other people. If there's a cut and there's a bloodstream infection, other people can also contract it when they come into contact with these samples. That's why it's advisable to protect yourself in the facilities when you are working on such infected people. Sometimes blood transfusion could also be an exit point for transmission of certain infections. So you can have several pathologic conditions. In the case of latency, you can have initial symptoms showing, especially in the chronic infections. Then they stay dormant, they recur, stay dormant, recur again in the same individual. And in some cases, they may shed it into the environment. Some cases, they will not shed it into the environment unless they get to other sites. So if the person is recovering and does not fully recover, you can have latency achieved. And sometimes the symptoms or the disease could become more severe if the numbers rise above what was initially seen. Chronic carriers also have the latent infection, and these are capable of shedding into the environment. We can have long-term permanent damage to tissues or organs as a result of these latent or chronic infections. That's why it's better to always complete the treatment course and test again to see if the organisms have been fully cleared. Otherwise, if the host is left unmanaged, they could lead to long-term or permanent damage, and this is referred to as sickly. There can be sources. Okay, so we can have a reservoir, which could be an animal, human being, soil, water, or plants, the environment. This is where the organisms are harbored. So the human being could be the reservoir. Please mute. Please mute. So this is the primary habitat of the infectious agent. And mostly, because these are primary habitats, some of them will not show symptoms in the case of the humans and the animals. And they can transfer or shed these into the environment, or others come into contact with them and they are able to get the infection. So when you talk of a source, we can have the individual being a reservoir and a source at the same time. The source is where the infection is actually acquired. So it can be an object, a sharp object that is contaminated with blood with the infectious agent on it. So if somebody has the infection, and then samples are taken, then you have blood on the needle. That needle could be an object, which is a source from which an infection can be acquired. Sometimes people cough in buses, in cars, so the seat could be a source of an infection. In the hospital, where you have patients coming in and going out, the OPD, the IPD could also be a source of an infection. It could also be an individual who will be the actual source of the infection. So a carrier is an individual who quietly shares the pathogen and then spreads it to others. So this carrier may not be a reservoir. So the carrier could be a health worker who picks an infected object, which is a source, and then goes to another bed and then well, the organisms are not living in this vagina. So we can have carriers that have the infectious agent in them. Can also have carriers who do not have the infectious agents in them, but because of the sources they carry. So in the case of the hospital or in some clinics, you could have one particular cap. So somebody is asking, can the carrier eventually become a reservoir? Yes, a carrier could become a reservoir if the object or the source actually infects the carrier and they multiply, they become chronic, and then that individual also shares the infectious agent. Or the carrier could only be carrying the source without having the pathogens inside him or her. It's when the organism is living inside the person that it becomes a reservoir, naturally. So we have some asymptomatic carriers who will not show symptoms. So these individuals are reservoirs, and then they shed the pathogens into the environment, or they transmit to other people. You can have those who are incubating the pathogen as a result of exposure and are capable of spreading the infectious agent. You can have those who are infected, they've reached the height of infection, they are responding to treatment, so convalescent carriers. And because they are getting better, they may not show symptoms, but are capable of spreading the infectious agent quietly. We can have chronic carriers. These are the ones that are dangerous. For a long time, they harbor these infectious agents and usually do not show symptoms and are always spreading the infectious agent. So if in the hospital you've noticed a particular patient who comes, gets treated, goes back, comes again. So if the infectious disease keeps recurring, it could be that there's a chronic carrier in the household who is constantly shedding the infectious agent, especially in the case of typhoid fever or malaria. You could have some people who are asymptomatic, they have the parasites, the gametocytes in them, and then they keep sharing with others. When mosquitoes bite them, and then they move to the other people. You can have passive carriers. So you have the contaminated healthcare provider who picks up the pathogen, but the healthcare, so he or she, and then patients. That's why we are practice health facilities. So we can have an individual lying but not showing symptoms, and they can easily come into contact with people and then share the infectious agent. You can also have somebody who is incubating and then shedding these infectious agents. Somebody who is infection, so but they have included the symptoms. A chronic care harbors the infectious agents, does not usually show symptoms. So we have such people in the health facility, the source of the infection. You can easily connect the matters and then spread it to patients. Evelyn. Oh, sorry about that. So should I repeat this slide?
Yes,
No, please.
Some are saying yes, some are saying no. All right, so let me go back. So we could have asymptomatic people, they have the infection, they don't show symptoms. So somebody is asking about the chronic and then the passive. So a chronic carrier has the infection. So the passive carrier does not have the infection. They only pick the infectious agent from a source. And mostly these are objects. And then transfer to other patients or other people. So this is passive transmission. They are not themselves infected. They just pick it from a source. And Angela, please mute. So we have those that are active carriers. They have the infection, and they could be the ones incubating, the ones who are getting better as a result of treatment, or those who are having the infectious agent for a long time, not showing symptoms. Or we can have the passive type who pick the infectious agent from a contaminated source and then transfer it to others. So in the case of transmission, we could have those who are asymptomatic carriers. They don't show symptoms, and then they go about shedding the infectious agent in the population. So if you have such asymptomatic people in the community or the health facility, then it's a problem. That's why we advise regular screening for health workers so that we know those who are harboring these infectious agents, and then they can be treated. We can also have people who have come into contact with the infectious agent and are incubating the pathogens. In some cases, such people could be coughing, and then the portal of exit could lead to transmission. For some diseases, they are not transmissible at the incubation stage. So it depends on the organism and then the condition. And some people can incubate the infectious agent for several months or sometimes several years before they show actual symptoms. Then we have people who feel the symptoms, they start treatment, organisms are not fully cleared, the host, organisms in the host, they come out maybe as a cough, as a pass urine or stool, or as samples are be taken from them, so blood samples, and accidentally another person gets the infection through that. We can also have people who are chronic carriers. So these people have the infection for a long time. They don't show symptoms, or the symptoms come and then disappear, come and disappear. And they can easily contaminate objects, or they can directly transfer to other individuals that they come into contact with. So for the active, have, and they can different, how the object is healthy, as long as environment is contaminated, that object could be a source of transmission to another patient who came to the facility but was not having that particular infection. And sometimes the health worker would go with an object that is not contaminated, but as a result of contact with the patient who has the infection, that patient, in the case of convalescent or somebody who is admitted, that object that the health worker is using could become contaminated and then transferred to another patient. So this is passive transmission. So we talk about the microbial infections. So first we talk of mycosis, fungal infections. So the study of fungi is mycology. That's why mycosis is a term for diseases that are caused by fungi. And we could have superficial infections by fungi. We could have cutaneous infections by fungi. And these affect the hair, the nails, the skin. So superficial, cutaneous affect the hair, the nails, and then the skin. Then the subcutaneous under the skin. Then you have systemic that spreads to several sites. So it can be deep mycosis, where the brain is affected. You have respiratory tract, respiratory system affected, where you have the liver, the kidney, the spleens also affected. So fungi can cause infection in several sites of the body. The is asking, does convalescent carrier also transmit the infectious agent? Yes. If you look at this, the person is recovering but has not fully cleared the pathogen. So once the pathogen is inside the host, they can multiply and then come out to infecting visitors. Especially when the person is responding to treatment. So why are you preventing them from seeing their family members? And usually after discharge of the patient, those family members will come back to the facility with the same condition, because in the course of time, health worker visiting those patients who end up becoming infected, because the convalescent individual can also transfer the infectious agent.
So this recover from
Is mute. Jamila, sorry. So superficial mycosis, we can have the external part of the body and then the skin become, unlike the cutaneous, the subcutaneous, and then the systemic. So we can have pityriasis vesicular, which is as a result of pigmented lesions on the trunk, the upper part of the body without the head. And these are external. So the skin is affected. Sometimes you can have the palms or the underfoot becoming affected, and this can be a condition called tinea nigra. You can have black pedra or white pedra or pedra blanca, which is as a result of dark or soft deposits on the hair. It could be white granules on the hair shaft as a result of fungal infections. And they are easy to diagnose. So we take samples from the hair, the skin, the nails, then you can observe under the microscope the microbial fungal cells. And because they affect the external part of the body, they are easily treated by topical applications. So in some cases, you could also take it orally and then treat such infections, but mostly topical application is ideal to treat such external or superficial mycosis. So this is a typical example of pityriasis vesicular, where you have pigmented lesions on the trunk or the torso. So this is fungal infection. So as the topical preparation is applied, the person also has to practice hygiene. So regularly changing the bed sheets or regular washing of the towels so that they don't keep the source of the infection, because the clothing, the bed sheets, the towels could be the source of infection. So after treatment, they could still come back and then have the infection. So we talk of the cutaneous mycosis or tinnitus. So tinea is not the organism's name. It's a collection of cutaneous mycosis. And these trigger inflammation, unlike the superficial. So cutaneous, subcutaneous, and the systemic, they trigger. Somebody is asking what of, yes, sponge. So mostly for sponge, because constantly we are using the soaps, sometimes they're able to kill some extent, but the towels and then the bed sheets, they mostly have the fungi. But it's advisable to be using, that's why we advise using shampoos that are having antifungal properties, so that once you are using the same sponge, the shampoo can kill whatever you have in the sponge as well. So cutaneous mycosis is associated with inflammation, but it also affects the external part of the body, the hair, the skin, the nails. And these are caused by fungi collectively called dermatophytes. So these affect the skins. And there are three groups of these organisms or these fungi that cause cutaneous mycosis, the dermatophytes. We have the microsporum, the trichophytin, and then the epidermophytin. These three form the dermatophytes. And they use a protein called keratin. This protein supports hair growth, nail growth, and then the skin texture. So if your skin will look healthy, keratin is one of the proteins that are needed. And these dermatophytes, the microsporum, the trichophytin, the epidermophytins, they feed on the protein keratin to get energy. And as I said earlier, they also affect the skin, the nails, and then the hair. So these three dermatophytes, they can be classified or seen in specific areas of the external part of the body. So the microsporum, although they use or they feed on keratin, usually they don't infect the nails. So you can have microsporum infection of the skin and then the hair, but not the nails usually. On the other hand, epidermophytins will infect the skin and the nails. They don't usually infect the hair. But the other group, which is the trichophytin, they infect the skin, the hair, the nails. And because they prefer the keratin for their source of nutrients, they don't invade other parts of the body that do not have keratin. That's why they are confined to the skin, the hair, and then the nails. And mostly you have the individuals complaining of itching. You have scaling of the skin patches, and mostly you have inflammation. And in some cases, you have fluid collections under the skin. And unlike the superficial, you can have these infections on different sides of the body. So the cutaneous mycosis, also referred to as the tinnitus, that's a collection of the cutaneous mycosis. It has several types depending on where they are infecting the body. So we have tinea corporis, which is ringworm, fleas, newts. Tinea capitis, also ringworm. So capitis is localized on the scalp. So on the head, you have capitis. If it has to do with the body parts externally, that is tinea corporis. If it affects the feet, then it's tinea pedis or athlete's foot. Then if it's affecting the beard, so barber's itch, that is tinea barbi. Sometimes you can have the groin affected, which is also jock itch, so that is tinea cruris. Then sometimes you have the toenails, fingernails affected, and that is tinea anguium or onychomycosis. So this is a typical example of tinea anguium, which affects nails. It can also affect the fingernails. They have tinea pedis, which affects the feet. So you can have scaly skin as a result of these fungal infections. Then you have on the scalp, tinea capitis. Then on the body, can be on the hand, on the thigh, on the leg, on the trunk, and this is tinea corporis. Then can have on the beard, around the mouth, tinea barbi. Then you can have at the groin, between the trunk and then the lower part of the body, you have tinea cruris or jock itch. So when it comes to diagnosis, because they affect the skin, the nails, and then the hair, samples can be taken from the affected areas, and then you can apply lactophenol blue stain in the lab, and then observe under the microscope, and then the hyphae, the branched parts of the fungal cells, will show the stains, and then they confirm as positive. You can also prepare direct mount with 10% potassium hydroxide and then observe under the microscope. You can also use UV light for detection of microsporum infections using the Wood's light. So there's a typical example of the Wood's light. You turn it on in the UV light will fluoresce when the microsporum is present in the sample. So just like the superficial, you can have topical and then oral treatment. So the fungal properties are also recommended later because it's not superficial. And because the fungal cells grow slowly, treatment takes time. So sometimes it can take about 8 weeks, 12 weeks, depending on the condition. So if the patient takes the medication and then stops along the line, it can have please. Then we talk of the subcutaneous mycosis. Under the skin, can have fungal cells also causing an infection. And these fungal cells or fungi, so somebody is asking the difference between tin and. So if we should go back, ringworm is just the general term for how the lesions or the pigmentations appear. Because they form a ring-like appearance. If you look at this one, it's like a ring. They spread in a ring-like form. But it's on the body, so it's tinea corporis. So ringworm could be on the scalp or ring form is what we require general term, but to qualify it, please mute. To qualify it, you look at where the body is affected. So if it's on the scalp, that is tinea capitis, and it's ringworm. If it's on the body, tinea corporis, but it's also ringworm. So somebody, where can we place scabies? We are talking of fungal infection. So it has to do with the infectious agent. Thank you. So we move on. The subcutaneous fungal infections or mycosis. You have these organisms mostly in the soil or on vegetation. Mostly affected because you see children playing around and they mostly have, and if accident because they are in the soil, they can find themselves into the sap and then imply and cause the mycosis. So they mostly affect the feet, but sometimes you have, especially the work on this, that's accidental inside the underside of the skin, and then they begin to cause the mycosis. So you can have the immune system trying to fight them, and then you have granulomatous lesions, and then they begin to expand slowly if treatment is not administered. So they usually do not spread to all parts of the body and become systemic. But if treatment is not given adequately, there are some patients who will wait till the last minute and then it becomes a problem. That's why it's good to have public health workers who visit the communities and then identify people who have such conditions so that they can be managed. So when people have cats, especially in the environment, on the farms, our attention should not be only on tetanus. We should also look out for subcutaneous mycosis. But mostly the immune system, if it's strong, is able to fight these fungi, and then the person does not develop the disease. And they are not usually transmitted from humans to humans. It has to usually do with cats or working directly in contaminated environments. And because of the weather conditions, that fever, fungi, these infections are common in tropics and then the subtropical areas. So this is a typical example of mycetoma, which is a subcutaneous mycosis, or chromoblastomycosis, which is also subcutaneous, but the signs are visible on the skin, the outer part of the skin. And sometimes they eat deep into the skin, and if treatment is not given, they develop into ulcers. So this is an example of sporotrichosis, also subcutaneous. Bridget, any problem? So all these are possible. That's why we advise people to be conscious of their environment. For some people, when they start feeling the symptoms, they don't care until it's very worse. And usually, especially those who work on the farms, if they have a cat, they step on something and then there's a cat, they don't pay attention to this, and then they could develop into the mycosis. They may be seeing them as ordinary wounds, and they will be applying the medication or systemic mycosis. Because to other sites, the immune system will try to fight them, and if they're able to break the barriers, then they spread to all sides. And fungi grow better around 37 degrees Celsius, which favors them in the human host. And for systemic infections, they need to multiply in large numbers. So the infectious dose is usually high for systemic fungal infections. And it's common and it spreads quickly in endemic countries or endemic areas. People who have the immune system compromised are not able to fight these fungal infections, and so it becomes more severe as the disease progresses. So those who have AIDS, those who have also grown old, are also at risk of systemic fungal infections. So you can have histoplasma capsulatum. So histoplasmosis, which is an example of systemic infection caused by the fungi, histoplasma capsulatum. These are mostly in the soil, but when you inhale them, they can quickly spread through the other sides of the body as they multiply by burden. So unlike binary fission. This one from the cells and then give rise to an independent fungal cell also multiply. And mostly they are asymptomatic, but they can spread to several sites of the body. Sometimes they are benign, but they can progress and become more fatal. If the immune system is compromised, especially those who are aged, then they become more at risk. You can have the lymphatic system also affected, so the spleen, the liver, which are part of the lymphatic system, begin to suffer, and then you have organ damage. Josephine, can you hear me? Please, if you hear me. All right. Josephine, can you hear me? Right, let's go on. We can also have blastomycosis, which is caused by blastomyces dermatitis. In the case of, you can't hear. Can someone else confirm if you can hear me?
Yes, sir, we can hear you.
Please check your
We
the
can
level
hear
of
you,
your.
sir. We can hear
All
you.
right, thank you. So,
Sir, we can
Justin,
hear
please
you.
check from your end. Right, thank you. So, this is also caused by inhalation of the spores of the. Thank you. Of the blastomyces dermatitis. And in the case of the skin lesions, they are mostly self-limited, but they can sometimes spread to other parts if treatment is not given promptly. And sometimes they can cause ulcers and advance and cause central scarring of the body. They can eat deep into the skin or the organs if they are not managed properly. So sometimes we misidentify such conditions and then associate them with Brule ulcer. So people will be treating these blastomycosis as Brule ulcer, and because they are using antibiotics and not antifungals, then becomes a challenge, and the build
Hey.
abscess or white blood cells as a result of this infection. And these can cause cancer or the tissues and clear their functions. So the bones, the teeth, the test, epididymis may not be affected. Other examples of infections, so aflatoxin is a chemical or compound that is produced, mostly you see them in